Hello and welcome to Bristol Health Cares. I'm your host, Kirk Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. Today we have a very special program. We have Dr. Stephen Caminiti. He's a critical care pulmonologist on staff at the hospital. He also has an ambulatory practice. Welcome, Dr. Caminiti.
Oh, thank you. It's great to be here.
So tell me about yourself.
So I have been at Bristol Hospital Health for 30 years now, which is an unbelievable thing to say.
Yeah.
I grew up outside of the New York area, and my parents were not college educated, and somehow I wound up, through good fortune and good advice, getting to Georgetown and then NYU and then Duke, and now being a physician and actually doing a job I have grown to love immensely.
Yeah. I mean, and I think there's not a person that wouldn't agree with what you just said, that you demonstrate that love for your job and what you do. So Bristol Hospital, how did that happen with all that background? I mean,
well, my wife was from Long Island, I was from New Jersey, and we wanted to come back this direction from where we were. And I didn't really want to go back to New Jersey, and she didn't want to go to New Jersey, and I didn't want to go to Long Island. And an opportunity came, and I met my senior partners at that time, Dr. Bondis and Dr. Tazinski, and they were people who I felt I could be very comfortable and work well with, and it has been a good decision.
Yeah, it's interesting that you talk about that personal connection that helped you make the decision, and I hear that so much. People kind of think sometimes, well, it's about the contract, it's about the money, it's about this, but you're making a choice, and you made a good choice because obviously you've been here for 30 years.
Well, I think it's most like a marriage. You spend a lot of time with these people, yeah, and you have to be able to get along and be able to resolve disagreements in a way that is helpful to everybody. Yeah. And if you don't respect and like the people you're working with, it gets very difficult.
Yeah. So talk to me about the ICU, because you're the director of the ICU critical care at the hospital. Talk about, that environment and the range of things we can do. And
so the ICU is where we take care of the sickest individuals in the hospital. Frequently it's used because somebody has a piece of equipment or needs some medication that we can only give in the ICU. And that's only part of what we do. Sometimes we put people in the intensive care unit to prevent problems and to make sure that problems aren't going to develop.
Yeah.
And that's a misconception I think people have all the time. We have a very dedicated group of nurses and respiratory therapists. We have the ability to do almost every mode of mechanical ventilation, to use a ventilator, yeah, that we need to. We can do a much advanced life support. What we cannot do is we cannot do heart surgery, we can't do neurosurgery, and there are some specialized things that we will transfer people for, but in many cases we can take care of those people here in the community, which I think is beneficial both for the patient and their family, yeah, because they can be cared for close by. In addition, they get taken care of by doctors who know them. We get to take care of patients that we see in the outpatient setting people I've known, some of whom I've known for 25 or 30 years.
Yeah.
And I think that there is great value in care being done by somebody who knows you.
Yeah, I totally agree. So I'm going to ask you a question. You know, I was a relative newcomer to the hospital and the community, and we were struggling financially, and the then current mayor chokes on steak at the one of the clubs in town, and ends up coming into the ER, and you actually did the hypothermia protocol on him.
We did, and he was a very successful outcome. Not all of them are that good, but that's the most gratifying part of being someone like me who does what I do, is that you see people who are on the brink of death, and then you can get them well and get them back to who they were beforehand. And I didn't know the mayor beforehand, but I got to know him afterwards, seeing him as a patient. And he was a wonderful man, and someone who you could have a nice conversation with. And the joy of doing that and being able to see him get back to who he was and do what he had done, and to get to know him is immeasurable.
You know, I have to say that, as you probably recall, I was in the ICU every single day because I was getting calls from people in the community saying, why is he there? You've induced him, you've put him in a coma, and he should be going to Yale or somewhere else, you know, to a tertiary care center. And so I would come upstairs, and his family would be there, his wife, Pat, and she would look at me and say, he needs to be here. He needs to be in his hospital. They're doing a great job. And it was a very nervous time for me because I wasn't sure, because I think he was the second patient that we actually put into the hypertension.
Yeah, he was early on in the program, yeah.
And I think the thing that I took away from that, aside from it all worked out okay, and we made national news because I had friends in Chicago and out on the West Coast calling me when he did a press conference on the way out of the hospital. Yeah. So you clearly did a great job with him. But I watched in amazement you working with the team, and it kind of struck me, there's so much science, but there's also art involved in that. And I don't mean art word, but I mean art in terms of that, you know, you're putting somebody into this state and their body temperature goes down and they're shivering, and you're trying to control this and you're trying to control this. And I was just amazed at how much of this process included like interaction. You mentioned respiratory therapists, the nurses, the doctors, everybody was working together as a team. It was incredible. It was an incredible experience to see.
The misconception is that I do this. The reality is that I am maybe directing what happens, but without talented and dedicated nurses and respiratory therapists and everybody else who takes care of the people we have, we could not do what we do. Nurses are there on the front line, and they are taking care of people all the time. And an experienced ICU nurse is a precious resource, because there are those that I've worked with now for 20 years, and they come up and tell me, I just don't like this.
Yeah.
That becomes something that I take very, very seriously, and I will go and look at things. Now, I may not agree with them, but I will tell them why. But there's no substitute for that sort of ability to be able to depend on people. And many nurses seem to have a sixth sense in taking care of these people. And that the relationships that I have with the people in the ICU are my second family.
Yeah.
They demonstrate a tremendous amount of care for me, which I am so thankful for. And their competency and compassion is what is unique about an ICU nurse. They are a very interesting combination of toughness and compassion that is hard to reconstruct. I wish I had that, but they are very, very wonderful individuals. Respiratory therapists are unsung heroes, especially during the last 3 years with COVID, because they would be taking care of people who had this contagious and potentially deadly disease, and they would be having to deal with the airway, which is where all of the viruses come from, and be in close contact with that. And we have a wonderful group of respiratory therapists who will set up a ventilator the way I set up a ventilator. And knowing that it's being done right without having to tell anybody is a very comforting fact.
So you mentioned the pandemic in the last 3 years, which have been, incredibly challenging for everybody. And here we are now, and it seems like we're starting to get back to normal. I remember participating in calls back in November about how we were going to get crushed this year by flu, RSV, COVID, and it feels like we're getting through this. But I also recognize that things can mutate, and there's always the risk that things could change. So talk to me a little bit about what's going on.
Well, I think we're in a different place. I think between the vaccines and the number of people who have had COVID, it is no longer a new virus to our bodies. And so it is more normal. The chaos of the last 2.5+ years is not there in the intensive care unit. I remember I was in Spain when COVID exploded, and I had to come back early, and then I got quarantined for 2 weeks. Yeah. And then when I came back to work and went into an ICU, it was an environment that I had worked in 30+ years that literally was a second home, and I walked into a place that looked like the moon.
Yeah.
And it was scary, and it was something that required learning a new way of doing things and becoming comfortable with a new way of doing things. And we adapted and got through that. But we are not seeing the severity of illness that we saw the last 2 winters. We're not seeing the numbers like we did the last 2 winters. So I think we are now getting to a place that is much more normal. Where that normal lands on the reality of how life goes, I don't know, but it's now to the point where if you're young and healthy, catching it is going to be more akin to a cold. People who have risk factors are going to still need to be more careful. But I think that springtime comes along, and hopefully it'll be a virus that is similar to influenza, and that we can take precautions in the winter and be freer in the summer.
That's great news. How about the long haulers, though? I mean, and I've met quite a few, and they're real. I mean,
oh no, they're real. That is an interesting problem. So that's going to be something that the people who are younger than me are going to figure out. Not that I wouldn't. It's not that it's not an uninteresting problem, but it is a problem that is not clearly understood yet. Yeah. These people clearly are suffering. You do testing on them, and there are some abnormalities that you see, but some things are not abnormal. Yeah. So they'll come in short of breath, and I believe they're short of breath because I can watch them, and they look short of breath. But then you do lung function tests on them, and they're more or less normal, and you do x-rays, and they don't really show significant abnormalities, but they're short of breath. And trying to figure out that is going to be interesting, and it's going to lead to a new understanding of how the pulmonary system works. This is, I started my career back in the early to mid 80s at NYU in medical school, and HIV exploded at that time.
Yeah, that was
and I saw a pandemic as a young doctor, and it was interesting because nobody knew a whole lot more than we did. And then when I left New York and went to North Carolina, I actually knew more than a lot of the people who were down there because I'd seen so much more. And now my career has been bookended by another pandemic where I am now the senior person and supposed to know these things, and not knowing any more than anybody else did at the beginning of this was a humbling experience.
Yeah.
But if you look at what happened with HIV and how we figured this out and how it has more or less become a chronic disease, I have every confidence that over time, all these smart younger people will figure this out. The people suffering may not like that answer, but I think at some point we will figure it out.
Yeah, it's amazing how rapid, I mean, just for example, the vaccine, how rapid the vaccine was brought to market. Yeah. I mean, not to market, I mean, we all got it. which was amazing.
That was what has been done in the last 3 years is a testament to what the medical profession can do when smart people worldwide put their mind to a single problem, and focus on it to the exclusion of everything else. It is a great feeling to be part of a profession that is capable of doing something like that.
It is.
And those people did Nobel Prize worthy science to be able to get to this point.
It's interesting, there were a lot of fear about vaccines. I mean, we had a committee, we worked through that. When I said we all have it, not everybody got the vaccine. Some people chose not to have the vaccine. In the state of Connecticut, we made the commitment as healthcare workers to make sure that everybody was vaccinated. I was talking to a hospital CEO from Dominion Republic yesterday, and it was quite interesting to hear, the conversation about vaccines and drugs. I mean, he was boasting a very low infant mortality rate because they were able to get vitamins to the expectant mothers through the Pan American kind of organization. And so I asked him the question. I said, so how do people feel about taking those vitamins? And he goes, when they come to the clinic and they walk out, they protect them like they're gold. They absolutely take them. And I said, well, then how do they feel about getting the vaccine? And he goes, everybody's got 4 shots. I said, so there's no sense of, like, oh my God, I shouldn't do this. I'm fearful of it and everything else. And he said, absolutely not, Card. Everybody's got a card with 4 shots on it. It's really kind of an interesting contrast when you think about a third world country in some respects, on the border of Haiti, and here we are, people are arguing over it. And I know you were a very strong advocate for the
Well, we're
vaccine.
a victim of our own success. So we don't see the consequences of these illnesses that we have vaccines for anymore. Do anybody know anybody who's had polio? I
know one.
Right, in pulmonary medicine.
I know one doctor that had it who works with us.
In pulmonary medicine, we still will see people who have respiratory compromise as an older age as a consequence of having had polio.
Yeah.
The old iron lung, these people didn't need the iron lung, but now they are, between the muscle weakness and many of them have scoliosis, they will compress their lungs, and as they get older, it gets worse, and they become compromised from a respiratory standpoint. So the consequences of these diseases that we no longer see are substantial.
Yeah.
But we see them in the medical profession, but nobody knows out in the community, nobody knows anybody who has it anymore, because we have had such great success. Vaccines are based on 200-year-old technology and science. We have medications that are months old that people will take, but won't take a vaccine based on 200-year-old science. It's really disappointing.
Yeah, as a doctor, I'm sure it's frustrating, and I know there were times where you'd have someone who didn't believe in the vaccine, and there they were in our ICU during the pandemic, and really hard for the staff and for everyone to watch that. And that doesn't mean that necessarily the vaccine would have saved them, but the truth is it might have given them a better chance.
It was disappointing when we had something that could have potentially stopped them from getting that ill.
Yeah.
Now, there's no certainty in life, and all we can do is to increase the chance that a good outcome is going to happen. And when that isn't taken and people get really sick, it gets disappointing. And the way people died from COVID was horrific.
Yeah.
And to prevent that would be worthwhile in our minds.
Yeah, I understand that. So let's talk a little bit about the ambulatory practice, the office practice, and the kind of things that you treat on the pulmonary side, because all of the critical care doctors are pulmonologists who take care of pulmonary conditions.
Right. So the mainstay of our outpatient practice will be COPD, or what a layman might think of as emphysema. That's going to be the most of the patients that we see. We also see patients with asthma, and then we see people with whole host of other less common problems. As I said, polio, sleep apnea falls into the pulmonary purview, and one of our doctors is this board-certified sleep medicine person who has taught me a tremendous amount in her time here.
Dr. Kumar, she's awesome.
Yes, she is. Then we will see things such as pulmonary fibrosis. We see respiratory infections, chronic cough, which sounds like no big deal for somebody who takes care of sick people. But if people who have a chronic cough will tell you that they don't feel well, even if cough is just due to postnasal drip. And when we can figure out and make them stop coughing, you feel like they've changed their life. So it's a very gratifying practice, and we deal with the sick people in the ICU, and then after you're full of that, you go back to the outpatient world and get to see what normal people are like. And then you go back and forth, and as I said, and then you can see people who were sick in a hospital, and then you see them not as a normal person.
Yeah.
I remember one time when I was a young physician, we had this 17-year-old girl with lupus who was horrifically sick in our ICU. And I was walking through the outpatient area a few months later, and she says hello to me with her mother. And I had no idea who she was because she looked so much different than she was in the ICU. And to see that she was now back in school and happy and doing things a 17-year-old is a great feeling.
Yeah, it has to. But you just said something I never realized, but people can have a chronic cough that has nothing to do with any serious condition. It could just be postnatal, and if you fix that, they feel better.
Yes, because
that's amazing. I didn't know that.
Think about what happens when you see somebody coughing. You think they're sick.
Well, right. For the last 3 years, you get scared and you walk away.
And there were a number of people who said, please, could you do something about this? Because that's the experience they had. But from a chronic cough standpoint, about 70% of them are postnasal drip.
Really?
And as long as you're not a smoker and you have a normal chest x-ray, 70% are postnasal drip, about 15% are asthma, and 8 to 10% are reflux. So none of those are necessarily life-threatening diseases in general. Asthma can be, but all of them can impact somebody's quality of life. And figuring that out and improving their quality of life is what we're supposed to be doing.
Yeah, so it's a full-range pulmonary practice, covers everything. We have amazing doctors, and we have all the testing that you need, diagnostic testing.
Well, there are things that we would send somebody out for because we don't have the resources, and it's the right thing to do.
Yeah.
But seeing someone like us so that you can be pointed in the right direction in the most efficient fashion is worthwhile from a patient standpoint. Yeah. Because we can direct you as to what you need to have done. For example, I just had somebody who had a lung transplant about 6 months ago. And I saw him, I talked to him about being evaluated, was able to point him in a direction of getting evaluated, and then he got listed and got transplanted fairly quickly afterwards.
Wow.
But so having somebody who knows a good deal about your problem so that they can help you get it taken care of in the most efficient fashion is worthwhile.
So now post-transplant, that person's back in our community being followed by you.
I see him, but they, especially the first year after transplant, they're constantly in that transplant center. And that's the appropriate way of being cared for because they know the nuances of what happens when post-transplant. As they recover from transplant and they get further out from it, then I will see them more than they probably get seen down in the transplant center.
It's kind of an interesting thing because my brother had a transplant, and I didn't realize that when the approval process includes like all the care, everything for a whole year. They don't go back for more approvals, which means that care is usually provided at the transplant center for that time frame. So.
Well, they have a vested interest in making sure that people do well after transplant.
Yeah, sure.
Statistics are
absolutely
are capped and they're public, but they also are doing it for the right thing because it is a completely different specialty of medicine. You're replacing the problem that you have with the disease of transplantation, and you need to be taken care of by the specialists in that disease process.
Yeah, that's interesting. I guess I never heard it that way before, but I understand. So in terms of like advances What do you see next?
That is so hard to predict because when I go back to the mid 80s, CT scans were just really becoming common to do.
Yeah.
MRIs were in their infancy. Laparoscopic surgery was just really starting. And to see where we have come, now I just saw in the paper today that about, the hospital at home. I think as our technology gets better, that sort of thing will probably become more apparent that it's the best way of taking care of patients.
Yeah.
I think that, I think there's all kinds of things that can happen, and you just don't know where it's going to go. 3 years ago, you might have gotten a different answer. And then 2 weeks later, 2 weeks after that, almost 2 weeks after today, 3 years ago, we were in a completely different reality. And so you just don't know where this is going. There's so many advances that came from the research into HIV that have leaked out into all of the rest of medicine. It is, our understanding of virology has probably changed. And just in the last few years, the ability to do rapid testing of respiratory pathogens has changed how we take care of people. We're now able to identify people having RSV and a number of other respiratory illnesses that we didn't do 3 or 4 years ago routinely. Yeah. And it makes caring for people easier because you have an answer. And sometimes it's simple things like that that can make a difference, and sometimes it's just tremendous advances, and both of which happen in medicine. So it's a great field from that standpoint.
So what do you think, Dr. Caminiti? We have like an average life expectancy of 82, or are we going to get to 95, 100 at some point?
That's dependent upon people's behavior. Okay. Most diseases that all adults die from now have to do with our behavior.
Yeah.
Smoking, drinking, lack of exercise, all of which will impact our life expectancy. And so I think there is a certain limit to the human lifespan, and more people will get closer to that. Whether we'll extend it dramatically is a question in my mind, but I think the idea is you're seeing it now. You see more people making it into their 80s and late 80s. And I think you'll see more and more of that because we take care of diseases that people die from earlier at a younger age.
Hopefully, yeah. So last thoughts to the public, parting words. What would you like them to know or think about?
That both that medicine is there for them, that Bristol Health is there for them, and that there are a number of good doctors who take very good care of their patients on an everyday basis. It may not be sexy and it's all of, get the headlines, but a lot of what we do is routine, but it doesn't make it unimportant. And that we do care for your health, and we would like to see you to take care of you.
Awesome. Thank you, Dr. Caminiti. This is another episode of Bristol Health Cares. And I want to say a special thanks to Nutmeg TV for producing this. They do an amazing job here. This is an amazing facility. And as I've said in the past, please email us with your questions and concerns. What do you want to know about? The email is cares@bristolhospital.org. Again, that's cares@bristolhospital.org. I am Kurt Barwish, your host, and I'm looking forward to seeing you in the next episode.